Hi, good evening, everyone. Just a bit. Okay, right. Let us just start with the session. Let me just. Okay. So I welcome you all to Unacademy. Let us start with this session, and let us start with this revision program. But before that, let me tell you about some important things. Okay, so please do make use of Unacademy and its resources. And there are some schemes going on. Yeah, and we have one of the best, you can say, technically advanced resources. So let us quickly start with this session. Okay. So the first thing that we are going to talk about is this question. So this is a very easy question, but you will have to tell me about some incisions here. Okay. Yeah, Ashka, hi, walaikum assalam. I hope you're fine. Everyone, hi. So let us start with this session and tell me about this. These incisions are very important for your exams. It's a very easy question, but it's a very important question. So let us start with this question. Yeah. So what are the incisions which are shown in this image? Yeah. So can you see what are the incisions which are shown here? So if you talk about, let us see one by one. What is the incision number 1? Okay. What is the incision number 1 and what is the importance of that? So incision number 1 is a midline vertical incision. What is it? It's a midline vertical incision. Now when we talk about midline vertical, what is so important about this incision? Where do we use this incision? Yeah. Let us see. This incision is made for laparotomy. So this is the ideal incision that we make for laparotomy. So what is this? This is this midline incision, midline vertical. Now let us try to understand what are the other incisions that we have. The incision number 2. If you see the incision number 2 is a right subcostal incision. So what is a right subcostal incision? This is a right subcostal. And this right subcostal, this incision is also known as, can anyone tell me what is the name of this incision? Something from K. This is known as coccus. Coccus. So this is known as a coccus incision. Coccus incision. Now where do we use this coccus? You know, there are a lot of coccus that we have. So there are 2 standard coccus incision. What is the right subcostal, which is used for cholecystectomy. So CBD procedures, all the CBD procedures that we do, we require a coccus. All the gallbladder surgeries that we do, we require a coccus. And one more coccus that you make over the neck. And what is that? That is for thyroidectomy. So remember, coccus incision. What is the utility of coccus incision, students? It is for gallbladder, and this is also used for CBD procedures, CBD surgery. So this is a coccus incision. Now if you see this incision number 3, what is this incision number 3, students? Yeah. Incision number 3, this is thoraco abdominal incision. So incision number 3 is thoraco abdominal incision. Now what is the importance of thoraco abdominal incision? Remember, this is an incision which is required when you want to enter into the retroperitoneum for renal surgeries, when you want to do any surgery on the diaphragm, or you want to enter into the mediastinal cavity or aortic surgeries. So aorta. So this is required for aortic surgeries. This is required for renal surgeries. So this is required for renal surgeries. This is required for diaphragm surgeries. Diaphragm surgeries. Now, what are these incision number 4 and 5? If you see these incision number 4 and 5, they are the incisions which are no more used. Yeah. So 4, it is rectus splitting. So 4 is rectus splitting incision. And what is this rectus splitting incision for? This is old and obsolete incision which was used for gallbladder, for cholecystectomies, for CBD procedures. Then the fifth incision that you see is a paramedian incision. So paramedian incision, what is the utility of this paramedian incision? The paramedian incision was used for laparotomy. So paramedian incision was used for laparotomy, and today this incision is also not used. So remember, the rectus splitting and the paramedian, they are no more used now. Now if you see the incision number 6, so what is the utility of this incision number 6? Let us try to understand. 6 is a transverse incision. So where do you make this transverse incision for? Students, transverse incision is made for pancreatic surgeries. So pancreatic surgeries and specially difference. Now do you know, I will draw one more incision for you. Just try to follow this. What is this incision? Can you see? Let me label it 6A. Again I am going to draw it for you. Just follow this incision. Yeah? This is this incision. What is this incision for? This 6A. What is this 6A incision for? Anyone? Anyone? What is this? Yeah. Yes, you can use it. Yes, they yeah. You can use it transverse for pediatric laparotomy also. No issues. But basically transverse is used for pancreatic surgery, and also the 6A. This is a chevron or a rooftop incision. A chevron or a rooftop incision. So chevron or a rooftop incision. So phalansteal incision is used for gut, for GUT surgeries, for LSCS, and also during laparoscopy when we want to extract a big specimen. So this is what is very important. Next, let us see the incision number 7, 8 and 11 and 10 in the next page. So let us try to understand what are the incisions that we make for appendicectomy. So when we want to do appendicectomy, then we make certain incisions. And what are these incisions? Let us try to understand them. So remember, there is a point which is known as McBurney's point. So this is McBurney's point. Now when we talk about McBurney's point, where is this point located? This is a point located on the spino-umbilical line. Now what is the spino-umbilical line? It is a line which runs from ASIS up to the umbilicus. So this is umbilicus, and this is suppose ASIS. Medial and lateral 1/3, we have a point which is known as McBurney's point, and actually this is the point which is going to mark the location of appendix. So perpendicular to that incision, perpendicular to that, you are making one incision, and this is what is known as McBurney's incision. So let us say this to be A. Yeah? So let us say this to be A. So what is A? This is McBurney's. Do you know this McBurney's incision? This is also known as MacArthur incision. This incision is also the incision which is known as gridiron incision. So splitting incisions. So they are very important, and they are muscle splitting incisions. Now sometimes when you are operating, nowadays no one is operating open appendicectomy. Very strategically, very poor surgeons are only doing open appendicectomy. No one is. Why? Because when you do laparoscopic surgeries, you get a big room inside the abdomen. So the surgery becomes a lot easy. So no one is doing, but still if you are doing, and there was a time when the surgeon felt that the space is less. In order to increase the space, you can extend the incision laterally, or you can extend the incision medially. So if you see, this is known as lateral extension. Lateral extension. Students, lateral extension of any incision can be done, and similarly the medial extension. The medial extension of any incision can be done. So we can have medial extension, we can have lateral extension. Remember, if you do medial extension, this is known as Fowler-Weir extension. So the Fowler-Weir extension, this is the medial extension, and this is what is known as Rutherford-Morrison. So remember, Rutherford-Morrison is not having any individual entity. It is the flank extension or lateral extension of any incision. And similarly, medial extension, this is Fowler-Weir. Remember, extensions are muscle cutting. So extensions, they are muscle cutting incision. So this is all that we have to discuss about this question. Let us see this question once again. I hope this is clear. So now let us do one more question. Let's do. Okay, so now we'll do this question. So just tell me something about this question. Identify the condition, identify the surgery being done. Yeah. Identify the condition and identify the surgery being done. This is a very easy question. What are you seeing? A midline neck mass. A midline neck mass. And whenever we have a midline neck mass, what are we thinking on terms of? Yeah, we are thinking on terms of that it could be a thyroid swelling or it could be a thyroglossal duct cyst. Yeah. So thyroid swelling or it could be thyroglossal duct cyst. However, we have not given any I'm not given any such information in the question. But by seeing this and by correlating it with another diagram, you can see the hyoid has been, this is the hyoid which has been transected. This is the central hyoid and there is a cyst here. So we come to a conclusion that the image that we are dealing with is of thyroglossal duct cyst. Very good deal. So let us try to go to the next page and discuss something important. So whenever we have a midline neck swelling, what are the two DDs? Very close DDs. So midline neck swelling, we are always confused between a thyroid swelling, and it could be a thyroglossal duct. So thyroglossal duct as well as a thyroid swelling. Now try to understand the development of this thyroglossal duct or development of thyroid. So if you see the development of the thyroid, the primitive thyroid develops in two parts. One is the medial embryonic part, which is known as medial enlarged, and one is the lateral embryonic part, which is known as the lateral enlarged. So when we talk about the development is in form of lateral and the medial parts. Remember, the lateral part is derived from the ultimobrachial bodies of the neural crest, and it is the main medial part which helps in development. Now try to understand why I am telling this story. We'll come back to that. So medial enlarged, it is the medial enlarged which gets extended into a bilobed peduncle or peduncle. You can say pedicle. So this is a bilobed pedicle. And this bilobed pedicle will actually suspend the medial embryonic part, and this is now going to fuse. So fusion will now happen. Do you know the pedicle of this bilobed structure? This is known as thyroglossal duct. So one thing is clear, that the thyroglossal duct, the bilobed part of the thyroid, they're all having the similar origin from that medial enlarge. Now what happens? Now let me tell you one very interesting thing. As the fusion starts, so as the fusion happens at 5th week of life, this bilobed structure undergoes fragmentation. It starts to undergo fragmentation. So I'll show that part. So now what will happen? Just see. So fragmentation of this duct. So the moment there is fusion, there is also fragmentation, and therefore regression of this thyroglossal duct starts. So regression of thyroglossal duct starts just after the fusion, and therefore it starts at 5th intrauterine week and it is completed by 8th intrauterine week. This is very important. So this is completed by 8th intrauterine week of life. Always remember, in body there is also a last date of submission. If you have to submit anything, if you have to omit anything, you have to do it by 8th week of life. If something persists at 8th week of life, it is to be seen in the newborn also. Always remember, whatever has to be added by 8. Whatever has to be deleted by 8th week of life. So always remember that failed regression of thyroglossal duct by 8th week of life. So failed regression of thyroglossal duct by 8th week of life, and this is going to result in persistent thyroglossal duct. Now there are a lot of things which are persistent, but they never convert into a cyst. Why this thyroglossal duct converts itself into a cyst? Now this is also a very simple concept, that this thyroglossal duct is present. Now this is persistent and it is present in a newborn. So you should be knowing that thyroglossal duct is lined by columnar epithelium. So what type of epithelium is present? Columnar epithelium. What type of columnar epithelium? Pseudo stratified. So pseudo stratified ciliated columnar epithelium. So pseudo stratified ciliated columnar epithelium is present, and because this is a columnar epithelium, it will always have mucin secretion, and if mucin secretion is there, students, slowly this will transform itself. That is why even though cyst may not be present at birth, the thyroglossal duct starts its enlargement, and slowly it becomes converted into a cyst. So always remember that cyst is congenital. Point number 1, that cyst is congenital, and the presentation of the cyst is by 2nd or 3rd decade of the life. So 2nd or 3rd decade, you get to see a cystic transformation. Now, what is the fate of this cyst? The fate of this cyst is just like a balloon. If you keep on blowing a balloon, either someone will get irritated and puncture it and bust it, or it will itself get ruptured off. So bache, you have to understand the fate of this cyst is rupture. So it has to undergo a rupture, and when it undergoes a rupture, either it may be iatrogenic, or it may be a spontaneous rupture. So there are so many cysts, congenital cysts also, which get ruptured and they just dissolve, or they just you can say resolve. But this cyst is a special cyst. The moment it gets ruptured, it gets a way to empty its secretions, and therefore it will never dry up and heal, and there will be epithelialization here. Why? Because these are the cells which will keep on producing something or another, and this will keep on secreting, and here is the founding stone for thyroglossal duct fistula. So always remember that fistula is acquired and cyst is congenital. Now this is very important. Let me come to my previous question. What was that? Whenever you have a midline neck swelling, how to confirm that it is a thyroid or not? So since these swellings are enclosed within the pretracheal fascia, you will see the movement with deglutition. So movement with deglutition, yes, it will be there for both of them. The second thing is, since thyroglossal duct cyst is connected to the base of the tongue, the moment you protrude the tongue, you ask the patient to protrude out the tongue, the cyst should move up and thyroid swelling should not. So movement with protrusion of the tongue, movement with protrusion of tongue. So answer is the protrusion of tongue. Who will move? This will move, but this will not move. This is how you confirm it. So let us come back to this question. All except are true. So we have got the diagnosis that this is a thyroglossal duct cyst. One thing is clear. Now, it is lined by columnar epithelium. Absolutely true. Infrahyoid location is the most common. Majority of them, they are located near the hyoid. It may be suprahyoid, it may be infrahyoid, it may be juxtahyoid. So yes, this is absolutely true. So this is also true. This is also true. En-bloc cystectomy. Now when you have to treat this, you will remove the cyst. You will remove the cyst, and along with the cyst, the block which contains it. So what is contained here? It is contained with the hyoid. So central hyoid, central part of hyoid bone, and along with that, the cyst is also going to be removed. And what is this surgery known as? Yes. Hi MB, hi Surya, good evening. So what is this known as? This is known as cyst trunk surgery. Cyst trunk surgery. Actually, on this platform, the live comments are not visible. So that's why I'm not able to read your comments. But very soon I will do that. I'll make an arrangement so that the comment section is also going on this screen. So try to understand. Now this comment, let us come to this point. It may be associated with MTC. Now try to understand, medullary thyroid cancer is a special neuroendocrine cancer which is because of neuroectodermal cells from the intimobrachial bodies. Now when I was showing you the development, I told you about one very interesting thing, that actually this medial enlarge is going to give rise to thyroglossal duct and majority of the follicular cell. So it can be associated with cancers from the follicular cell, but never from the cells of the lateral enlarge. So any cancer can occur, but MTC can never occur. So MTC can never occur because the origin of the cells of MTC is totally different. So let us move forward and let us discuss one more small question. Okay. So answer me this question. Identify the lesion and the grade. Identify the lesion and the grade of this. First of all, what is this? This is a bed sore. Or you can say it is a pressure ulcer. Or what else it could be? It could be decubitus ulcer. Okay, so tell me what grade it is. Let us talk about the grading. So when you talk about grade 1, it is only blanching of the tissue. So blanching or erythema of the tissue is grade 1. What is grade 2, students? What is grade 2? It is partial thickness. It's a partial thickness ulcer. What is grade 3? It is a full thickness ulcer. And what is grade 4? It is grade 3, that is full thickness plus involvement of deeper structure. Structures. So what is this now? Anyone from the audience? Can you see this image? This is the full thickness has been lost, and along with that, muscle is also involved. So the muscle is also involved in this case. If you see the muscle is getting involved. Along with that, here the bone is also visible. So muscle plus bone is involved, and therefore I will mark this to be a grade 4. A grade 4. Very good, Shyam. You're getting this grade 4. So now let us discuss few important things about this pressure sore also. So let us give 2 minutes and discuss this pressure sore. So I hope the answer is C. So when we talk about the decubitus ulcer, this is nothing but pressure mediated necrosis. So pressure mediated necrosis of dependent part in patients on chronic immobilization. So in patients on chronic immobilization. Now I want to ask you, what is the most common site? Come on, tell me. So what is the most common site for them? Come on. Can you tell me most common site? Remember a mnemonic. I have made one mnemonic. It's a very bad level of mnemonics. So, but it works. So I remember it like this. It's He-man, that is ischium. So ischium greater than trochanter. So ischium greater than trochanter, that is greater trochanter, greater than sacrum, greater than heel, and greater than malleolus. This is what? Ischium, trochanter, sacrum, heel, and malleolus. Let us try to understand the pathophysiology, why actually it happens. So let us see that also. Suppose if you see this is the skin, yeah, and this is the external pressure. So P external, you have to understand that in between the skin and the capillary. So this is the capillary which we are referring to. There is subcutaneous fat. So whenever there is P external, the subcutaneous fat acts like a what? Shock absorber. Now when you talk about capillary, you have to understand one vessel or one term, and the term is what is COP? What is COP? The word COP is capillary occlusion pressure. So what do you mean by capillary occlusion pressure? The capillary occlusion pressure is the pressure required by the external surface, or you can say by the external source, to occlude the lumen of the capillary, or in the other terms we say capillary occlusion pressure is the pressure which is required to collapse a capillary. Now normally it is 30 to 32 mmHg. Is that clear now? So try to understand, if P external increases more than COP, there will be ischemia of that part because collapse of the capillary is there, and ischemia is going to lead to necrosis, and necrosis is going to lead to ulcer or gangrene. I hope this is clear to all of you. And that is why in this pressure ulcers or decubitus ulcer, weight offloading is very important. Why we do weight offloading? Why we use water mattress? Why we use air mattress? So that we can give that similar subcutaneous shock absorbing effect. So what is the management? When we talk about the treatment, the first thing that you have to do is debridement. Why debridement? Because necrosum, necrotic tissue, will consume all the local wound oxygen and it will not allow the healing. So debridement plus antibiotics to prevent infection, because necrosum is an excellent culture bacteria. So along with this, weight offloading is very important. So for weight offloading, we have air mattress, we have water mattress, etc. So weight offloading is done, debridement and antibiotics have been done, and plus minus you can use a negative pressure dressing. What is this term for negative pressure dressing? Can anyone tell me? Negative pressure dressing. So negative pressure dressing, this is also known as anyone? VAC. What is VAC? Vacuum assisted closure. So let me tell you about the VAC. Suppose this is the wound. So this VAC is nothing but a negative pressure dressing. So there is a carbon foam, and then there is a pipe which is connected with a machine, and this machine is going to generate negative pressure. So this negative pressure is going to remove all the purulent necrotic material minus 125 mmHg. It is going to siphon off all the pus and the necrotic material, and hence when pus is not there, oxygen level at wound is increased. Basically, why? Because necrotic material is not going to absorb everything, and thus the wound healing is expedited 2 to 2.5 times. So this is what is about VAC. Plus minus, some people might require a graft or a flap repair, a graft or flap reconstruction. Now, one very important question that comes is how to go for prevention. So if you talk about prevention of pressure sores, you always have to understand in immobilized patients, you have to advocate or promote the posture change. So change of posture is very important. I'm going to ask you, what is the standard duration? Debridement means we are removing, curating of the unhealthy tissue until and unless the fresh red bleeding tissue is there. So you will keep only the viable tissue, you will remove all the necrotic tissue. So regular change of posture. Now change of posture, what do you mean by this? Remember, every 3 hourly for bedridden patients. So for bedridden patients, we are going for every 3 hourly. And remember, if you have a wheelchair patient, every 10 to 12 minutes, for 10 to 12 seconds for chair-ridden patients. So this is all that you need to know about this question, and this is all for today's session. If you enjoyed Unacademy, yes, do join Unacademy, download the app, take use of the special classes. The only thing that you have to need is you need to sign in the app, download it, and use a code Dr. Dixit. You can use any educator's code. You can use my code Dr. Dixit, and do recommend Unacademy to your friends. Do give your feedbacks in the comment section, and do follow me on Unacademy channel so that you don't miss any notification of my classes. So that is all for today. We'll meet tomorrow again at the same time. Till then.